Welcome to the AOT Pod, an all-new FRCS-themed podcast, tackling key themes, challenging topics, and insightful intellect within otolaryngology. Hosted by Livy Kenyon and myself, Kalako Moraison, with the support from the ENT UK Foundation and AOT. Your guide to passing the ENT FRCS starts here as we take you around the country speaking to some of the best and brightest minds our specialty has to offer. So without further ado, let's begin.
Thank you. So today's theme is choanal atresia, and I'm pleased and privileged to be joined by Ms Lizzie Kershaw, who is a consultant paediatric ENT surgeon based in Leeds. Welcome, Lizzie.
Thank you.
So first of all, just to get us started, could you tell me when did you sit your exam and what was going on in your life at the time of your preparation for it?
So I took my part 1 in January of 2021 and part 2 in the following April. I'm sure you'll be aware it was in the middle of the pandemic. I actually took the exam and 2 weeks later I moved house, and 2 weeks after that I had abdominal surgery. So it was quite a busy time.
Oh my God, you packed it all in at once. So, I mean, it sounds like there was probably some considerable challenges when you were studying. How did you manage to balance everything around that?
I probably had the advantage of lockdown, meaning that nothing else was happening. So I didn't feel like I was missing out on a social life. It was also the second cohort to take the exam. It was in person, but without patients. So they had an opportunity to practice things, which did help. And we were quite established at that point with Zoom and Teams and doing all of the practice and things like that online, which actually was really helpful because it meant less travelling around and hanging out at people's houses or different hospitals, which probably made everything more efficient, I would say.
Yes, I can imagine. So having said all of that, how did you feel and how did you celebrate when you passed the exam?
I was so relieved. I was at my pre-op assessment appointment when I found out that I passed, and I think I cried a bit, and then I drank some champagne, and we couldn't go anywhere because it was still locked down, but it was a big relief for it to all be over.
Yeah, I'm sure. Well, congratulations again. So we'll move on now to the clinical scenario. The situation is you're the consultant on call and you get a call from the neonatologists about a newborn. The obstetricians have just delivered a 36-week-old. The baby is struggling to breathe, is going blue, though it gets better with crying. They're worried about the baby and they would like you to attend to help manage the problem. Could you please explain your differential diagnoses for this patient and tell me how you would clinically evaluate them?
Okay, so I'm sure we all know that babies are obligate nasal breathers. And given the history of the symptoms improving on crying, my main differentials would involve obstruction of the nasal airway. My initial thought would be to rule out bilateral choanal atresia, although I'll also be considering piriform aperture stenosis or a nasal mass such as an encephalocele or dermoid. I'd tend to review this patient urgently given the airway concern, but while taking the call from the neonatologist, I'd ask for the anaesthetic team to be contacted so that we could get their support and manage the patient together. My main worry when I get there would be how to secure the airway. This could be with an oropharyngeal airway, so like a Goodell, or with a McGovern nipple. Although you'll probably find that a lot of the time with these cases, by the time you get there, the patients have already been intubated. Then evaluating the child, the easiest thing to do is to hold a cold metal speculum under the nose, see if there's bilateral misting, and try and pass an 8 French catheter to see if they have patent choana bilaterally. You could examine them with a paediatric nasendoscope, but you'll often find that these children have a lot of mucus in the nose, so the view's not great. But if you can pass the nasendoscope, then you know you've got a patent nostril. You then need to consider if this is an isolated issue or part of a syndrome, and the most commonly associated syndrome is charge. If any features are present, they would have genetic testing, which can usually be organised by one of the paediatricians. You need to ensure the baby has an orogastric feeding tube, and you can organise a CT scan. At this point, usually they're intubated, so that's fairly easy to organise. If they have syndromic features, they might need further investigations such as an echocardiogram, and normally the paediatricians take the lead with organising these.
So you mentioned that there's different types of choanal atresia. Could you describe the background pathophysiology of choanal atresia for me?
Okay, so for those of us who are less experienced in ENT, the choana are oval-shaped openings that lie between the nasal cavity and the nasopharynx, right at the back of the nose. So they are rigid openings surrounded by bone. At the bony margins are the posterior edge of the horizontal plate of the palatine bone is the inferior margin. The medial pterygoid process is the lateral margin. The posterior border of the vomer is the medial margin. And then the roof is formed by the ala of the vomer, the vaginal process of the medial plate of the pterygoid process, as well as the body of the sphenoid. And choanal atresia is when that opening is no longer present. The development of choanal atresia is an embryological problem, so it's failure of recanalization of the nasopharynx due to a persistence of the bucopharyngeal membrane, failure of buconasal membrane rupture, and medial outgrowth of the horizontal and vertical portions of the palatine bone. In 1% of cases, it's membranous, in about 30% it's bony, and in 70% it's mixed. So mixed is the most common form that we see. When it's bilateral, this presents as an airway emergency, which we've already discussed, but it can be unilateral, and that often isn't diagnosed until later in childhood, and typically referred a child with a persistent unilateral rhinorrhea. Interestingly, it's slightly more common on the right than the left, and more common in females. It can be a standalone problem, but in about half of babies born with choanal atresia, they have an associated syndrome, which is the most common, and that's on the CHD7 gene. But it's also found in Cruzon, George, Treacher-Collins, and Pfeiffer syndromes, as well as some others.
Thank you. Could you tell me some more about charge, please?
Charge was previously known as an association, but in 2004, CHD4 was discovered as the causative gene, and at that point it was redefined as a syndrome. It's autosomal dominant in its inheritance pattern, and it causes a number of symptoms. And using the name is a helpful mnemonic to remember this. So C stands for coloboma, H for heart defects, A is atresia of choana, R, retardation of growth, G, genital abnormalities, E, ear abnormalities, and these can affect the outer, middle, or inner ear.
Okay, thank you. So going back to the clinical case, you mentioned that you would organise a CT scan. Could you tell me what the critical findings of this scan would be?
So we're looking for the nature of the choanal atresia. We want to know if it's membranous, bony, or mixed, as well as the status of the rest of the nasal cavity. Often children with choanal atresia have generally narrow noses, and this will help me plan my surgical approach.
So going on from there, what treatment options are available for these children, and what considerations do you make before offering them?
We treat choanal atresia surgically. The main challenge we find operating on these children is the size. The combination of their narrow noses and the stenosis can make surgery challenging. Normally we'd operate on the bilateral choanal atresia patients within the first few days of life once they've been stabilised. This gives us time to get the imaging, evaluate for syndromes, and discuss with the parents. In unilateral cases, we can wait until the child is a bit older, around about 2 to 3 years of age, as this is not only safer from an anaesthetic perspective, but the child has grown and there's more space in the nose to operate. When consenting the parents, we discuss how we do the operation, the risks of restenosis, general risks such as pain, infection, and bleeding, midfacial growth arrest if doing a vomer resection, saddling, and skull base injury. As mentioned, the child is usually already intubated and sedated. The surgery is usually performed via transnasal techniques. You can also use transpalatal techniques. Personally, I'd start by decongesting the nose and examining with a 0-degree nasendoscope. I'd then insert a Boyle-Davis gag and examine the choana posteriorly using a 120-degree endoscope. If you haven't had an opportunity to use one of these, I would recommend getting one out in the operating theatre and having a go practicing with it, because it is a very strange experience. I would then use either urethral sounds dilators to perforate the membrane and Higgins dilators pass through the nasal cavity to dilate the choana. While you're doing this, you can have a finger through the mouth on the posterior choana, and that ensures that you're palpating the tip of the dilator and not injuring the skull base. Once I've got an opening, I can then use a paediatric backbiter to do a posterior septectomy. Ideally, I'd do that under direct visualization, but sometimes it's not possible, and you may need to palpate the posterior choana again through the mouth with your finger to orientate yourself. If there's a significant bony element, I could then use a drill to drill the atretic plate, a diamond burr, after removing the mucosa, but often that's not required. The general difficulty with these small children is fitting the instruments into the nose to perform something like a posterior septectomy. It is very challenging. There's a debate around inserting stents to avoid restenosis. It's not part of my practice, as in my opinion it doesn't increase the success rate of the procedure, and it tends to create more problems, such as falling out early, causing granulation and scarring, and the stents themselves becoming blocked with secretions. After completion, we'd normally extubate them in theatre and then monitor them in HDU for 2 to 3 days to ensure they're feeding and breathing well and there's no restenosis. Post-operatively, we'd treat the patients with a saline nasal spray and alongside betnazole steroid drops as well. And we'd also treat any underlying reflux to give the best chance of successful outcome. I'd then expect to see the patient back in clinic after about a month, and I'd keep them under review for a couple of years until I'm happy that the procedure's been successful.
Thank you. That's very comprehensive. So now moving on, are there any classification systems that are used in choanal atresia?
You'll be relieved to hear that there's no complicated staging system to memorise. So it's just classified simply as unilateral, bilateral, and whether it's membranous, bony, or mixed.
Yes, I'm sure everyone's delighted to hear that. Are there any current limitations in the management of choanal atresia? And are there any literature that you think is relevant for people to know coming up to the FRCS?
The main debate will be that discussion around stenting. Reviewing the IPOD consensus recommendations, there has been a move in most people's practice away from routine use.
Thank you. Is there anything else that you want to mention about choanal atresia?
I'd say that a lot of the cases you probably won't get a completely successful outcome with one procedure. Most of these children will have to undergo several procedures. I have also had one case where there was so much bone at the back of the nose that reopening the choana wasn't achievable, and that child has gone on to have a tracheostomy.
Oh wow, that's interesting to hear. So thank you. I'm going to summarise now. Choanal atresia can be either bilateral or unilateral, and it can be isolated or part of a syndrome such as charge. Choanal atresia presents at birth with airway difficulty, which gets better with crying. When we evaluate these patients, the main aim primarily is securing the airway. Then we'd get a CT scan to evaluate them and organise further testing if there were any clinical features of syndromes present. Surgery is the mainstay of treatment, which is done using a combined transnasal and transpalatal technique, and the main challenges is around avoiding restenosis. Thank you, Ms Kershaw. It's been a really excellent session on choanal atresia. We really appreciate it. Do you have any final comments before we finish, either about choanal atresia or the FRCS in general?
I'm very grateful to have been invited to join in with this teaching experience. I wish everyone the best for their exams. I would just recommend lots and lots of Viva practice.
Thank you for your words of wisdom. Okay.
Thank you.
Thank you for listening, and we hope you enjoyed this episode of the AOT Pod. Be sure to check out our other topics and give us a like and subscribe to get notified when new episodes become available. For more educational resources, visit the AOT website, aotent.org, and our YouTube channel. and make sure you attend our national conference where there are prizes for oral and poster presentations up for grabs. See you next time.